Given the information, are these results acceptable? It is obvious that the patient has hyperkalemia, but what are the causes of hyperkalemia? There are three causes of hyperkalemia. One is shift of potassium from the intracellular to the extracellular fluid, as seen in vigorous muscular exercise, digitalis intoxication, and fluoride poisoning. Two is increased potassium intake. However, the kidney's ability to excrete potassium is so efficient that hyperkalemia rarely occurs in the basis of increased potassium intake. Number three is impaired renal excretion and may be due to decreased aldosterone or aldosterone responsiveness, renal failure, and reduced distal delivery of sodium. How do we differentiate pseudo-hyperkalemia and hyperkalemia? Pseudo-hyperkalemia is an increase in potassium concentration only in the local blood vessel, which may be seen in prolonged application of tourniquet and in vitro hemolysis. This condition has no physiologic consequences like ECG abnormalities, which can be seen in hyperkalemia cases. When evaluating elevated potassium results, and when hemolysis and contamination are already ruled out, look at the BUN and creatinine results if they are elevated. Creatinine is formed from creatine and creatine phosphate, which is formed at a constant rate and has a direct relationship to muscle mass. Therefore, its concentration varies with age and gender, which makes it higher in males compared to females. It is filtered by the glomeruli of the kidney and is not reabsorbed under normal circumstances. Its concentration is relatively constant, which makes it a good measure of renal function, particularly glomerular filtration. In renal disease, the creatinine excretion is impaired as reflected by increased creatinine in the blood. Urea, or the blood urea nitrogen, is a product of protein metabolism. Its concentration in the blood is determined by the amount of dietary protein and the kidney's ability to excrete urea. Therefore, an increased urea concentration indicates a flaw in the filtering system of the kidneys. An elevated potassium result on freshly drawn non-hemolyzed sample with elevated creatinine and BUN is acceptable.